All right. Hi guys. Good evening. Good evening. Can you all see me? Can you all hear me? Quick feedback. All right. Okay. Can you all see me? Can you all hear me? So how many lectures on Love and Bailey? As of now, we have completed 65 lectures. I think the whole series is going to be for 200 lectures. That's what the target is. I mean, like, that's the requirement for at least to complete the entire Bailey and Love. Hi, Dita. Right. So without wasting any further time, can we kickstart the discussion? So कल हमने क्या बात किया था? कल हमने बात की थी कि अगर पेप्टिक अल्सर डिजीज का पेशेंट आता है उसको कैसे मैनेज करोगे. तो सर्जिकल मैनेजमेंट फॉर द पेप्टिक अल्सर डिजीज, वी स्टार्टेड विद द मेडिकल मैनेजमेंट. Then we spoke about the surgical management. I told you the goal for the surgical management, it is to remove the disease site. If it is refractory, that is the indication for the management where hi Hector, good evening, good evening. Right. So we just started on the discussion on the management of peptic ulcer disease. Yesterday, I told you that there are three goals for doing a surgical maneuver. I can say a surgical component for a peptic ulcer disease. एक कि आप जो disease part of the mucosa और disease part per se has to be removed. Acid जो है वो duodenum में ना जाए, उसको bypass कर दो ताकि duodenal ulcers heal कर जाए. And if possible, decrease the acid secretion. I told you two different surgeries that you have, Billroth 1 and Billroth 2, that we discussed yesterday. Now, I'll just take a discussion to a next level where I'll be talking about the management of the gastric ulcer specifically on the basis of the modified Johnson's classification. Hi, good evening, Sovik. Right. So, if you remember, according to the modified Johnson's classification, we had the modified Johnson's classification. Now, according to the modified Johnson's classification, if you remember the whole component, right? What is type 1 gastric ulcers? You remember modified Johnson's type 1, quick feedback. You remember type 1 gastric ulcers? So I said the type 1 gastric ulcer which is present on lesser curvature, right? So this is the ulcer that is present on the lesser curvature. Then you have type 2 gastric ulcers. We said there are two ulcers. One is present on the body of the stomach. One is on the body of the stomach. Another one is on the first part of the duodenum. Then you have type 3 gastric ulcer, which is pre-pyloric. If somebody says how much is pre-pyloric, at what level will you consider this to be as pre-pyloric? Remember, this will be 2 to 3 centimeters from the pylorus itself. So this is going to be 2 to 3 centimeter from pylorus. From pylorus, it is a type 3. Type 4 is typical, which is high on lesser curvature. It is high on lesser curvature. And type 5 is NSAID induced gastric ulcer. It is the NSAID induced gastric ulcer. Raj will be talking about the complication of each surgery. Yes, Billroth does cause a lot of issues. We'll be addressing that. But for now, we're concentrating on the surgical options that we have. Right. So type 1 is present on the lesser curvature. Type 2 is in the body and the first part of the duodenum. Type 3 is going to be pre-pyloric. Type 4 is high on lesser curvature. Type 5 is going to be NSAID-induced gastric ulcer. Now, if I look at the entire prospect in the context of acid production, so if I look at the context of the acid production in each of these ulcers, so if I have to quantify the acid production in each of this, remember in type 1 it has low acid production, Type 2, it is going to be high acid production. Type 3 is also going to be a high acid production. Type 4 and type 5 is going to be a low acid production. Okay. So when we talk about the acid productions per se, you will notice that in type 1, it is going to be less. It is going to produce. Type 2, type 3, it is more. And type 4, type 5, it is going to be less, right? So what it tells you is in type 2 and type 3, you also need to do an acid reducing surgeries like Wigottomies, which are going to talk about it. Okay. Whereas in type 1, if you only, because the acid production per se is less, you can go ahead and remove that part. It is more than enough. Type 4, type 5 is going to be in the same context, because in type 5, it is NSAID induced. So there's no rocket science for the management of type 5. They ask you what is the specific management of type 5 gastric ulcer. The specific management, common sense should prevail. It is stop NSAIDs. तो अगर अल्सर बन ही रहा है NSAIDs की वजह से, तो NSAIDs बंद करा दो. दैट इज व्हाट इट इज गोइंग टू बी इन द कॉन्टेक्स्ट ऑफ इट. ठीक है. तो टाइप 5 गैस्ट्रिक अल्सर में आप सिर्फ NSAID बंद करा दोगे, दैट इज मोर देन इनफ. देखो टाइप 2, टाइप 3 में आपको एसिड रिड्यूसिंग सर्जरीज भी करनी पड़ेंगी, क्योंकि वहां पे एसिड प्रोडक्शन हाई है. बाकी हर जगह पे एसिड प्रोडक्शन लो है, तो उतना ज्यादा मारामारी करने की जरूरत नहीं है. तो व्हाट इज इंटरेस्टिंग फॉर अस इज द टाइप 4 गैस्ट्रिक अल्सर का स्पेसिफिक कंपोनेंट या फिर स्पेसिफिक मैनेजमेंट क्या है. ठीक है. तो जैसे आप बोल रहे हो कि देखो टाइप 1 में ज्यादा एसिड प्रोडक्शन हो नहीं रहा, तो यहां पे सिर्फ आइदर यू कैन गो अहेड विथ बिलरॉथ 1 और बिलरॉथ 2. यू कैन गो अहेड विथ बिलरॉथ सर्जरी. ठीक है. दैट इज टाइप 1. देखो टाइप 2, टाइप 3 में क्योंकि मुझे एसिड प्रोडक्शन भी रिड्यूस करना है, बिकॉज देयर इज मोर एसिड प्रोडक्शन, सो हियर आई वुड ऑप्ट with Billroth surgery. Along with Billroth, to reduce the acid, I will also go ahead with Wigottomy. Another way you can reduce the acid secretion. Now, if you're doing Billroth, obviously removing the antrum also. Specifically, if you want to do only acid reduction, antrectomy can also be a choice, right? Now, type 4 is slightly interesting, so I'm going to talk about the management of type 4 gastric ulcer. So, we're talking about the management of type 4 gastric ulcer. So look at the type 4 gastric ulcer. The type 4 gastric ulcer is going to be high on lesser curvature. So when you look at the whole component of this, take this esophagus, this happens to be the stomach, right? And I'm saying the ulcer is present somewhere across here, which is high on lesser curvature, right? Now, how do you approach this particular site? Because if I remove this much part of the stomach, there is hardly any stomach left, right? So it becomes very difficult for us to think about it. So what do you have? The first surgery that you have is what we call it as the Peptic surgery, which is also called as a shoemaker surgery. So what we do is, I'm going to remove this part of the stomach along with the antrum. So I'm just going to move it this way. So it looks like a shoe, right? So I'm removing the pyloric antrum along with this much part of the stomach. If you remove this and then make the rest of the anastomosis, this is what we call it as the Peptic surgery. This is what we call it as the Peptic surgery. This is what we call it as the Peptic surgery, or also commonly referred to as the shoemaker surgery. Is commonly referred to as the shoemaker surgery. ठीक है. एक option ये हो गया. Another option that you can have, now because this is of low acid secretion, right? So here you are only going to remove the pyloric antrum of the stomach. Okay? If you remove only the pyloric antrum of the stomach, not removing the ulcer per se. So ulcer is left here. And if I only excise the pyloric antrum of the stomach, here the ulcer is not excised. Here the recurrence is more. So this surgery is no longer preferred, but they thought if you remove the pyloric antrum, you reduce the G cells, reducing the production of hydrochloric acid. Hence the ulcer would heal, but recurrence is quite high. So this is what we call it as the killing mandibular surgery. This is what we call it as a killing mandibular surgery, right? Where the ulcer site is spared. You are not going to remove the ulcer site per se, right? Now the last one that you have, which is, let's say, more or less currently acceptable, is what we call it as the Sendes surgery, right? Let's try to understand. Nothing spectacular, almost the same, but this time the reconstruction is important. Esophagus, stomach, and the duodenum, which is here. And this happens to be the ulcer which is present here. So here what we do is we'll use the ulcer and the rest of the stomach will be removed, right? This is what we call it as the subtotal gastrectomy. So I've removed almost the entire stomach. Sometimes it can go all the way to the gastroesophageal junction. This much amount of the stomach is removed, right? Now you want to reconstruct it back. Now if I reconstruct by taking the duodenum directly, right? Once you're done, what are you left out with? We are left out with a small part of the stomach which is left here. So this is what the stomach is left behind, right? So the rest of the stomach is excised, right? Now, if I take the duodenum which is left here, so duodenum which is left here, if I take this duodenum and if I anastomose, we all know that the bile duct is going to come and open onto the second part or the terminal part of the second part of the duodenum, which is where the bile is going to come and flow. Now, if I go and take this duodenum, you can see duodenum here. If I directly take it up and anastomose, it will cause biliary gastritis. I don't want that to happen. So I'll close the duodenum. I've created a duodenal stump. I've created a duodenal stump. And now you have the jejunum which is present here. And the jejunum will continue into ileum, right? So if I just demark it down, this happens to be the duodenum, this happens to be the jejunum, and let's say from here it is going to be ileum, right? Now I want to recreate it back. So what I'll do is I'll take the same setup, okay, to make it more easier. We're just going to copy this setup. Okay. Now what I'm going to do is I'm now going to divide the jejunum somewhere across it. Usually from the duodenojejunal junction, this is your DJ junction, that is duodenojejunal junction, around 50 to 60 centimeters. I will divide the jejunum here, right? Once I divide the jejunum, I have two parts of the jejunum which is present, right? So one we call it as the proximal limb of the jejunum, which is here. This is the proximal limb of the jejunum. And this is what we call it as the distal limb of the jejunum. So there are two limbs, the proximal and the distal limb. So once you do this, now what you have created is you have the stomach which is readily available here. So this is what we have chopped it off. This is the rest of the stomach which is left. The duodenum is completely bypassed. This is the C loop of the duodenum that is present. And the jejunum is now divided. So this is the proximal end of the jejunum. This happens to be the distal end of the jejunum. Okay, right? So this is your duodenal stump. So no points for guessing. So this happens to be your duodenal stump. Just to highlight the duodenal stump, I'm going to give you the bile duct. The bile duct is going to come and open here. तो सेकेंड पार्ट के जो डियोडम के टर्मिनल एंड पे ना आपको बाइल डक्ट ओपन करता है तो बाइल यहाँ पे सेक्रेट हो रहा है, ठीक है. ये आपका प्रॉक्सिमल पार्ट ऑफ द जेजुनम है. जेजुनम का प्रॉक्सिमल पार्ट, jejunum का distal part, ठीक है. Now which part of the jejunum will you go and make an anastomose with the stomach? The stomach is here, right? So will you take the proximal end or jejunal? Now imagine if I take the proximal end and make the anastomose here, तो इसका खाना कौन खाएगा, right? If I take the proximal end of the jejunum and try to put it to the stomach, how will the food go? The food will come from the proximal end and it is now not going to go anywhere. It's going to duodenum, right? So logically, it is going to be quite simple that I'm now going to take the distal end of the jejunum and I will make an anastomosis. Okay? So you will take the stomach end which is present here. I have taken the distal end of the jejunum, right? Now I have mobilized the distal end of the jejunum, and the distal end of the jejunum is put across like this. So this is the distal end of the jejunum that have taken the loop across. So distal end of the jejunum is going to be here. So this is the distal end of the jejunum, goes into ileum and all that, which is going to be here. ठीक है, तो ये आपका distal end of the jejunum है. You have the C loop of the duodenum which is present here, and the proximal end of the jejunum is still left. So this is the proximal end of the jejunum. This you have covered the duodenal stump, so this has to be duodenum. This happens to be the distal end of the jejunum. This is the proximal end of the jejunum that is present. The bile duct is opening onto the second part of the duodenum. We are not doing anything to that. So bile is now being accumulated here. The bile will flow in this particular direction. Okay. Now what I'm going to do is I'm going to open up the jejunum here. Right. Once I open the jejunum here, I'm now going to make the anastomosis between the stomach and the jejunum. I'll make the anastomosis between the stomach and the jejunum so that the content or the food that comes into the stomach, via this end will now enter into the distal end of the jejunum. It will flow. Now the proximal end of the jejunum that is left here, I'm going to make an opening here, and I will make an anastomosis of the proximal end of the jejunum to the distal end, and the anastomosis will be covered. So what it does is this will allow the bile to flow from here, and bile is going here and the food is going to go, and together they will move, right? Clear? So you can see that whatever are we trying to do. So this is, if I just dictate them in form of steps, this is the step 1 where you have excised it. Step 2 you have divided. Step 3 you have made an anastomosis. Okay. So this, if you look at this, this is a fancy term to tell you that we have done a Ru and Y gastrojejunostomy. I have performed a Roux-en-Y gastrojejunostomy, and this Roux-en-Y gastrojejunostomy is given a fancy name, and the fancy name is what we call it as the Sandeep surgery. This is what we call it as the Sandeep surgery. Okay. Nothing spectacular. This is how you do it for type 4 gastric ulcers. So in the type 4 gastric ulcer, in the step number 1, I have excised the part of the stomach which had the ulcer, and the stomach which is left behind, this is the part of the stomach which is left behind. Now, whatever is there, I have to maintain the continuity of the stomach. I have to make an anastomosis. So I'll take the jejunum. Now, if I take directly the jejunum and do it, it will be a lot of pressure and tension. So to do it in a less tension wise, I am going to create a Roux-en-Y limb, and the Roux-en-Y limb is created in this particular fashion, right? So this is how a Roux-en-Y limb is there. You can see how the proximal end and the distal end are being combined together, how the distal end is being migrated to the stomach to make an anastomosis, and now you can see the entire surgery. So you have one for the bile, another one for the food, and together they form in a common channel, and this is what we call it as the Sandeep surgery, right? This is what we call it as the Sandeep surgery. So far so good. Did you all understand? Quick feedback. Is it clear? Is it clear? So these are the surgeries which are specific for type 4 gastric ulcers. Okay. So type 4 gastric ulcer में Pochet है, killing Mandler surgery है. Then you have the Sandeep, which is also called as the Roux-en-Y gastrojejunostomy. Roux-en-Y is far more better when compared to Billroth, because Billroth is going to be associated with more tension. Roux-en-Ys are tension free. But अब Billroth 2 was initially done. अगर आज पूछोगे कौन सा preferred है, तो obviously आपका Roux-en-Y ही preferred है. तो मैं आपको chronology समझा रहा हूँ ना कि पहले बेटा Billroth 1 आया, फिर Billroth 2 आया, फिर Roux-en-Y आया, तो हमको ये समझ में आया ना कि Billroth 1 Billroth 2 से difficulty है, तो इसीलिए we are now moving down to Roux-en-Y. So Roux-en-Y is much more easier for us to understand, and it also gives us a more leverage. Clear hai? Is it clear? Can we move on? बेटा ये जो सेंडस सर्जरी है ना, अगर ये समझ लिया, that means your orientation is good and I've done a decent job in a manner to give you that understanding as well. Can we move on? Sure. So this was specifically with respect to modified Jansen's or type of your gastric ulcers. Now, continuing the discussion on the management of this peptic ulcer disease in the form of surgeries, another surgery that you can do is your gastrojejunostomy. Okay? So basically, this gastrojejunostomy was created as an acid diverting surgery. So as I told you, हमारे तीन goals थे. क्या क्या था? Remove the disease, acid diversion, decrease acid secretion. So your gastrojejunostomy is purely a acid diversion surgery. Is it a acid diversion surgery? See? Now, what is this acid diversion surgery? Let's try to understand this as well. Take this as a representation of the stomach. This happens to be the duodenum. This happens to be the jejunum, and this continues into ileum, and this is the terminal ileum. Okay? So we'll have a very clear-cut demarcation of what are we going to do. Beta, nowadays we prefer Roux by beta. So this is the stomach. This is the duodenum. This happens to be the jejunum, and this happens to be the ileum. Okay? The differentiation is quite clear. So when I say there is a gastrojejunostomy, right, I will migrate the limb of the jejunum and make an anastomosis with the stomach, and that is what we call as a gastrojejunostomy. Okay? So in a gastrojejunostomy, I will now migrate this part of the jejunum and then anastomose with the stomach so that the content which is going to come into stomach goes directly into jejunum, bypassing the duodenum. मुझे duodenal ulcer heal कराना है ना, तो मुझे वो acid rich content I don't want to go into the duodenum, so I'm going to make a bypass. ठीक है, तो ये अचीव कैसे करोगे? ठीक है, तो this is the esophagus, this happens to be the stomach. कोई दिक्कत नहीं है, duodenum अपनी जगह पे है, jejunum यहाँ पे है, लेकिन हमने क्या किया, jejunum को यहाँ पे माइग्रेट करा लिया. तो jejunum we have taken across here and we have aligned the jejunum like this. तो ये आपका jejunum चला गया, ठीक है, and obviously it will going to continue into ileum. So we have done nothing else. Everything remains in its position. If you say this happens stomach, this is the duodenum, this entire part is the jejunum, यहाँ तक आपका jejunum है, then यहाँ से आपका ileum. So what you did is you have opened this part of the jejunum and you have opened this much part of the stomach. ठीक है, तो jejunum और stomach को खोल दिया. Once you have opened it, now you have made an anastomosis between these two. You made the anastomosis between the stomach and the jejunum so that whatever you consume, whatever you're going to consume, the food that goes into the stomach via this site, it will go directly into jejunum and then it will flow into ileum, which is going to be present. The bile that is going to flow into the duodenum, which is here. The bile that flows into the duodenum, it will be here, and from here, you'll see from here, this is going to go all the way. Okay? Now, this is what we call it as a gastrojejunostomy, right? Now, they say what are the ideal characteristic of a gastrojejunostomy? If I have to give you a characteristic features. So, the ideal characteristics of GJ, that is a gastrojejunostomy. Remember a small mnemonic which is called as PV ring. This is what we call it as the PV ring. PV ring is the ideal characteristic. P, it should be posterior anastomosis. It should be a vertical anastomosis. It should be a retrograde anastomosis. It should be isoperistaltic. Isoperistaltic. It should be no tension. it should be no tension and no loop. G is your gastrojejunostom. Right. So the ideal characteristic of a gastrojejunostomy is it should be a posterior anastomosis. It should be vertical in orientation. It should be a retrograde suture method. You should use an isoperistalsis. That means the peristalsis of the stomach and the peristalsis of jejunum should be in the same direction. You can't have peristalsis of the stomach like this and the peristalsis of jejunum in the opposite direction. You can't have this. So they both, the peristaltic wave should match. So it should be an isoperistaltic, no tension, no loop. Gastrojejunostomy is the ideal characteristic of your GJ, and this is what we call it as the ideal form of gastrojejunostomy, right? So this is in terms of acid diversion surgeries. Okay? Now when you talk about acid reducing surgeries, we have Wigottomies. Okay? So we're talking about Wigotomy, again a very, very interesting component here. So when you talk about the Wigottomies, the basic concept of Wigottomy is to decrease the acetylcholine. And if you go back to our physiology of the acid secretion, okay, I've done a detailed explanation of how and what stimulates and what stops. And there I told you the most potent stimulator of the parietal cells is going to be a acetylcholine, that is vagus. In order to stop that, you have to do a Wigottomy, right? So basically the surgery, the goal in Wigottomy, it is going to decrease the acid secretion. It reduces the acid secretion. Now, in order to understand the whole concept, there are three forms of Wigottomies that we have. There are three forms of Wigottomies that we have. We'll discuss all three of them. We have the truncal Wigottomy. We have the truncal Wigottomy. Then you have the selective Wigottomy. Then you have the highly selective Wigottomy. So there are three different forms of Wigottomies that you have. You have a truncal Wigotomy, you have a selective Wigotomy, and then you have a highly selective Wigotomy. What is the basic difference, right? If you go back and remember our basic orientation, right? If you remember, now if you take this as the representation of the stomach, this was the esophagus, this happens to be the stomach, and this is the duodenum, right? For the sake of understanding, I'm just going to highlight this as the diaphragm, right? We had two vaguses. One is your right vagus, another one is your left vagus, right? If you remember, the left becomes anterior, the right becomes posterior. If you remember, this happens to be the right vagus, this happens to be your left vagus. So the left vagus is going to become anterior when it is coming into the stomach. The right is going to become posterior when it goes into the stomach, right? Now, major branches, we're going to talk about it. Now, from the left vagus, you have the hepatic branch, which is present here. From the right vagus, you have two major branches. One is your criminal nerve of Grisci, another one is going to be a celiac branch, right? So if you have any doubt, we have already covered extensively in our surgical lecture about the vagus. Vagus kahan gaya, vagus kahan gaya, vagus here. Okay? So you can see the branches which are present. I'm just highlighting the important one. The left vagus, it is the hepatic branch. The right is going to be celiac branch and the criminal nerve of Grisci. The same thing I'm going to depict it here also. So here you can see from the left vagus, it is going to be the hepatic branch, which is going to supply to the gallbladder. From the right vagus, you have the celiac branch. We have the celiac branch. One second, guys. You have the, I'll just write it, celiac branch. Another one that is going to be going across here is your criminal nerve of Grisci. Your criminal nerve of Grisci. Now at the end you have this crowfoot nerves which are present on both anterior and the posterior surface. This is what we call it as the terminal nerve of letargia, right? So these are your crowfoot which is present. This is what we call it as the terminal nerve of letargia. Now from each individual you'll also see the smaller branches which are present. These are your seromuscular branches which supplies to the stomach. Which supplies to the stomach person. So these are your smaller branches. The smaller branches is what we call it as the seromuscular branch. So this is your seromuscular branches, right? Just for the sake of understanding. This is your seromuscular branch. This is your criminal nerve of Gracie. This happens to be your celiac branch. This happens to be your hepatic branch, right? This is the orientation of the vagus that we have. Now, if you've understood this now, the surgery is a piece of cake. Same thing we are going to replicate here. Same thing we are going to replicate here. Okay, so what is a truncal Wigottomy? What is a selective Wigottomy? What is a highly selective Wigottomy? In the truncal Wigottomy, I am going to resect the vagus here, just below the diaphragm, where all the major origins are going to happen. This, if I like it, this is what we call it as truncal Wigottomy, right? In a highly selective Wigottomy, I will spare the major branches. I'm sparing the hepatic branch. I will spare your your celiac branch as well as criminal nerve of Gracie. If I do it this way, this is what we call it as the selective Wigottomy. If I only go and ligate the seromuscular branches, this is what we call it as highly selective Wigottomy. ठीक है, इतना ही डिफरेंस है, कोई ज़्यादा डिफरेंस है ही नहीं. ठीक है, तो इफ़ यू सी इट वेरी केयरफुली, अगर मेजर ब्रांचेस के ओरिजिन के ऊपर आप रिसेक्ट कर रहे हो, उसको आप ट्रंकल विगोटमी बोल. इफ यू आर स्पेयरिंग, सो whichever I circle, नो, वो हम स्पेयर कर रहे हैं. तो अगर आप हेपाटिक ब्रांच स्पेयर कर रहे हो, अगर आप सीलियाक ब्रांच स्पेयर कर रहे हो, क्रिमिनल नर्व ऑफ ग्रेसाई स्पेयर कर रहे हो, देन वी कॉल इट ए सेलेक्टिव विगोटमी. अगर आप सिर्फ और सिर्फ सीरोमस्कुलर ब्रांचेस को लाइगेट कर रहे हो, नथिंग मोर, इफ यू आर ओनली लाइगेटिंग द सीरोमस्कुलर ब्रांचेस, दैट इज द प्रिंसिपल सप्लाई ऑफ द स्टमक और इट इज स्टिमुलेटिंग द पैराइटल सेल्स. अगर वो लाइगेट कर रहे हो, इसको आप बोलते हो कि ये आपका हाईली सेलेक्टिव विगोटमी है. ठीक है, क्लियर? थैंक यू राज, बट आई अंडरस्टैंड सर्जरी, तो मेरे हिसाब से सर्जरी ठीक पढ़ा लेते हैं, तो वही पढ़ाएंगे, कोई टेंशन नहीं लेंगे. ठीक है, चलो, थैंक यू सो मच फॉर योर लवली काइंड वर्ड्स, बट आई ट्राई टू कीप इट सिंपल एंड गिव योर विजुअल इंटरप्रिटेशन सो दैट यू डोंट मिस अक्रॉस इट. तो ये आपके 3 वैरायटीज ऑफ विगोटमी है. ट्रंकल विगोटमी है, सेलेक्टिव विगोटमी और हाईली सेलेक्टिव विगोटमी. प्रॉब्लम क्या है, जब भी आप whenever you're doing a truncal vigotomy, you are compromising the celiac branch. ठीक है, जब आप celiac branch compromise कर देते हो, it is going to compromise what it is going to compromise, it is going to compromise the peristalsis. तो ये ना क्या करता है, gastric stasis cause कराता है. ठीक है, whenever you are doing, just for the sake of understanding, whenever you're doing a truncal vigotomy, the truncal vigotomy is known to cause or it will result in development of gastric stasis. ठीक है, क्योंकि स्फिंक्टर रिलैक्स ही नहीं होगा. अब गैस्ट्रिक स्टेसिस को ओवरकम करने के लिए यू नीड टू डू समथिंग कॉल्ड एज अ ड्रेनेज प्रोसीजर, राइट? यू हैव टू डू समथिंग कॉल्ड एज अ ड्रेनेज प्रोसीजर. यू हैव टू डू समथिंग कॉल्ड एज अ ड्रेनेज प्रोसीजर. ठीक है, तो ड्रेनेज प्रोसीजर का बेसिक गोल ये है कि वट एवर स्टेसिस is caused because of failure of that sphincter mechanism, you have to recreate that. ठीक है, तो ड्रेनेज प्रोसीजर में ना मेरे पास 2 ऑप्शंस है. हाउ डू यू क्रिएट अ ड्रेनेज प्रोसीजर? either I can go with Heineken Muclitz pyloroplasty or a Jabelois pyloroplasty. ठीक है, so try to understand both. Either I can do a Heineken Muclitz pyloroplasty Heineken Muclitz pyloroplasty, or you can go ahead and perform a Jabulois pyloroplasty. You have two options. Either you can do a Heineken Muclitz pyloroplasty, or you can do a Jabulois pyloroplasty, और यू कैन डू अ जैबुलॉइस पाइलोरोप्लास्टी. ठीक है, दोनों का बेसिक मीनिंग समझ लेते हैं क्या है ये ड्रेनेज प्रोसीजर. ठीक है, सो इन अ हाइनिकन म्यूक्लिट्स पाइलोरोप्लास्टी व्हाट आर वी गोइंग टू डू, right? It's a very simple thing that you're going to do. This is the esophagus, this happens to be the stomach, and this happens to be the duodenum. Okay, now at the junction where you have, this is the sphincter that is present, right? So I'm going to incise this area in a longitudinal manner. So ये line of incision. ठीक है, so once you incise this, you have created a defect here. So the defect is created in this particular manner. So I've incised it. The stomach is opened like this. I'm going to hold one end of the junction here, another end of the junction like this. I'm going to pull it across. जब मैं इसको pull करूंगा ना, मेरा जो ऑब्जेक्टिव या फिर जो फाइनल रिजल्ट होगा, स्टमक विल रिमेन एट इट्स पोजीशन, दिस जंक्शन इज गोइंग टू स्ट्रेच लाइक दिस. ठीक है, तो क्योंकि आपने इसको खींच दिया, द रेस्ट ऑफ द डियोडनम विल कंटिन्यू टू रिमेन लाइक दिस. आई एम नॉट कॉन्ट्राडिक्टिंग दैट. तो ये डियोडनम हो गया. अब बिकॉज यू हैव स्ट्रेच्ड इट लाइक दिस, this end is now become like this. ठीक है, because I have held this end and I've stretched in this particular manner. I've held this end, I've stretched in this particular manner. Now I am going to suture this in this particular fashion. ठीक है, so what you have done is you have incised it along the axis, that is longitudinal, but you have sutured it vertically. ठीक है, so this is what we call it as the Heineken Muclitz pyloroplasty. The sphincter is now damaged. Now because of this there is no stasis, because you are not dependent on the sphincter to open. अब वो passage ही आपने खोल दिया, इसको आप बोलते हो Heineken Muclitz pyloroplasty. This is what you call it as the Heineken Muclitz pyloroplasty. Is that clear? Quick feedback. Heineken Muclitz pyloroplasty समझ में आया? Did you all understand the Heineken Muclitz pyloroplasty? Quick feedback. Is it clear? Is it clear? Quick feedback. I'm waiting for your chat box. Okay, so when you talk about the Jabulois pyloroplasty, again, nothing spectacular about it. In the Jabulois pyloroplasty, again, if this is the esophagus, this happens to be stomach, and this is the duodenum that is present here, right? Now this continues across in this particular fashion. Okay, same thing, this is the stomach, this happens to be duodenum, this happens to be the jejunum. So what I'm going to do is, in this I'm going to mobilize the duodenum closer to the stomach. Okay, once I mobilize this, the end result is going to be something like this. You have the stomach, you have the duodenum. Now the duodenum is mobilized closer to that of the stomach. It is mobilized closer to that of the stomach, and the rest will continue across here. I will open up the duodenum here and the stomach here, and now I am going to suture these two ends. So I've sutured the stomach to that of the duodenum, so that whatever content that flows, whatever content that flows in, so there is no problem with stasis, because now it is going to go like this. Even if the sphincter is present here, now we are least bothered. ठीक है, रहने दो स्फिंक्टर को यहाँ पे, मुझे कोई दिक्कत है ही नहीं. I have bypassed the duodenum, and this is what we call it as the Jabulois pyloroplasty. This is what we call it as the Jabulois pyloroplasty. ठीक है, so this concludes all the surgeries that you have for your peptic ulcer disease. ठीक है, so what are the surgeries that you have? When you look at the entire list of the surgeries, slightly extensive, but you know it. You have Billroth 1, which is a gastroenostomy. Then you have Billroth 2, which is a gastroenostomy. Then you have, based upon the modified Johnson's classification, you have type-specific surgeries that we have mentioned, including the Roux-en-Y gastroenostomy, which is called as Sendus. Then you have acid diversion surgery, which is called as a gastroenostomy. I've told you the ideal characteristic of gastroenostomy. Then you have the types of Wigottomies which are going to be present. ठीक है? बाइलिंगुअल भी तो बोल सकते हैं सर. बाइलिंगुअल कुनवर आई डिड नॉट गेट, मतलब क्या बोलना चाह रहे हो? कि आप बोलना चाह रहे हो कि बाइलिंगुअल लैंग्वेज यूज करें या फिर कोई बाइलिंगुअल सर्जरी बता रहे हो? ठीक है, तो वेगोटमीज के 3 टाइप्स हो गए, ट्रंकल, सिलेक्टिव, हाईली सिलेक्टिव. ट्रंकल में बताया जस्ट बिलो द डायफ्राम, ट्रंक पे लाइगेट कर दिया. सिलेक्टिव में मेजर ब्रांचेस प्रिजर्व कर ली. हाईली सिलेक्टिव में सिर्फ सीरोमस्कुलर ब्रांचेस को लाइगेट किया है ताकि you will be able to only compromise the supply to the stomach and not the complications. Now problem क्या है, जब भी आप ट्रंकल विगोटमी करोगे इससे गैस्ट्रिक स्टेसिस होता है. तो गैस्ट्रिक स्टेसिस को प्रिवेंट करने के लिए आप ड्रेनेज प्रोसीजर यूज कर सकते हो. वी हैव 2 स्टैंडर्ड ड्रेनेज प्रोसीजर्स दैट आर देयर. एक तो हाइनिकन म्यूक्लिड्स, अनदर जैबलॉइज है. प्रेफर्ड आपका हाइनिकन म्यूक्लिड्स ही है. ठीक है, क्लियर है? इज एवरीबॉडी क्लियर विद अस? So this is all in all with respect to the surgical management of peptic ulcer disease. ठीक है, थोड़ा extensive है, but every single thing has been mentioned in the Bailey, so I thought it is more important for us to go through it and you understand it better. ठीक है, चलो, if you have no questions, thank you so much for joining today. We'll resume back next week. I just took this extra class so I can finish the surgeries. The next class that you have, हम बात करेंगे कॉम्प्लिकेशंस ऑफ पेप्टिक अल्सर डिजीज एंड इट्स मैनेजमेंट एंड द पोस्ट ऑपरेटिव कॉम्प्लिकेशन ऑफ ईच इंडिविजुअल सर्जरीज. ठीक है, तो दैट विल समराइज योर पेप्टिक अल्सर डिजीज. तो पेप्टिक अल्सर डिजीज में 2 चीजें पढ़नी है. इसके आगे एक आपको पढ़ना है कि पेप्टिक अल्सर डिजीज के कॉम्प्लिकेशंस क्या है और उसको आप मैनेज कैसे करोगे. दूसरा है कि जितनी भी आपने अभी सर्जरीज की है ना, उनकी कॉम्प्लिकेशंस क्या है, उनकी स्पेसिफिक मैनेजमेंट क्या है. तो आगे चल के हम ये 2 चीजें पढ़ेंगे. Until then, thank you so much for joining. तब तक, you know, if you want to reach out, you can always reach out to the surgery guy. कोई सवाल, कोई शक, कुछ भी हो, आप सीधा यहाँ पे you can put it across. This is by my name, that is Dr. Sandeep Reddy. You have the same, ये जो चैनल है द सर्जरी गाई, ये आपको बोथ इंस्टा एज वेल एज टेलीग्राम दोनों में मिलेगा. सो दिस विल बी बोथ ऑन इंस्टा एज वेल एज ऑन द टेलीग्राम. ठीक है बेटा, बाइलिंगुअल ही पढ़ाएंगे. वी विल यूज बोथ हिंदी एंड इंग्लिश. आई वुड वांट टू हैव मोर ऑडियंस ताकि बहुत बाकी लोग भी बेनिफिट कर पाए. तो कोशिश रहेगी कि ना जितना भी अपना सीरीज है वो हम हिंदी इंग्लिश दोनों में बना के पढ़ाएं. ठीक है, चलो, थैंक यू सो मच फॉर ज्वाइनिंग. Until then, until next week, take care, have fun, read well. Any questions, any queries, reach out us here. ठीक है, चलो, bye, good night, thank you so much for your time, bye bye.